this important topics. One is urodynamics and another is POPQ classification. Actually, these are both are very short topics, but some people find it very difficult to understand this, and then it becomes difficult to answer the questions also. But once you learn it, it becomes very simple. Okay, then you will not go wrong with any question. Okay, once you get your concepts clear. Okay, so we will start it. So first we will be starting with urodynamics. Okay, so 1 minute, I will share the screen. Can you see this, all of you? Can you see? Yes, please reply.
Yes, ma'am, we can see.
Okay, okay. Okay, so there is actually previously there was no clear-cut information for urodynamics, but in 2019 they have given this beautiful talk article. Okay, and it has given beautifully all the aspects like how to do, when to do, and all the things regarding urodynamics. Okay, so it has become much easy. Only thing in that talk, there is one big table of artifacts, and people are usually scared of that table. But remember it well that there is no need to do that artifact table. Okay, not at all required that artifact table. Only thing you should know regarding the common diagnosis, what are the things and how to do it, what are the indications for urodynamics. These are the basic things, and how to interpret the urodynamic graph. Okay, so that is the basic thing that you should know regarding the urodynamics. Okay, so yes, what is the definition of urodynamics? So yeah, these are the observations which are made during a variety of investigations to objectively assess the function or dysfunction of lower uterine tract, lower urinary tract. Okay, so see, these are the observations, and these are not made during a single test, but there are different tests available. So like it can be a simple urodynamics, ambulatory urodynamics, video urodynamics, only uroflowmetry, or only cystometry. Okay, so these are different types of tests in which some observations are made. Okay, and these are usually, this is the assessment which is done objectively. It is not subjective. Okay, it is objective assessment, and it will assess the function of lower urinary tract. Okay, and what this observation includes, it includes measurement of physiological parameters of bladder filling and voiding. So what you're going to study in the urodynamics is basically how the bladder responds to the filling and voiding phases. Okay, so is there any dysfunction during this filling phase and voiding phase that we have to identify, and simply that is the urodynamics. Okay, so it should include all measurements that assess the function and dysfunction of the lower urinary tract by any appropriate method, including cystometry and pressure flow studies. And what is the aim of this urodynamics? It is to reproduce the pathophysiology and symptoms in an artificial setting. So it's not that whole day you are going to do this urodynamics. It is for some period of time, but it is going to reproduce the symptoms in artificial clinical settings. Okay. So now what are the indications of urodynamics? So there are so many indications, but according to our point of view, whatever MRCOG examiner, whatever urogynecological point of view, there are only 4 indications, and remember these all indications very well. Okay. Hmm? So before surgical treatment of urge incontinence, okay, previous failed surgery for stress urinary incontinence, in mixed incontinence where predominant type is urge incontinence or predominant type is not known or cannot be determined. Okay, and in case of stress incontinence when it is associated with either anterior or apical prolapse or voiding dysfunction. So to make it simple, what I will tell you is, for any medical management of urinary incontinence, whether it is a stress or mixed or urge incontinence, you don't require urodynamics. Okay, for surgical management of urge incontinence, you require urodynamics, but for surgery for stress incontinence, you don't require. Okay. Even in case of mixed incontinence, when predominant type is stress, you don't require. But in predominant type is urge, you require the urodynamics to be done, or when the predominant type cannot be determined. And in case of stress incontinence, when it is associated with other complications like prolapse or voiding dysfunction, so then you require, so in complex cases only you require urodynamics, not in simple cases. Okay, got it?
Yes, ma'am.
So now when you are not going to do, remember that well so that you will remember the indications. So in case of pure stress urinary incontinence, you don't require urodynamics. For any conservative management of incontinence, you don't require urodynamics. And when there is a mixed incontinence with stress predominance, you don't require urodynamics. So if you remember these three, what are the way not to do, then you will remember the indications. So remember, there are only 4 indications of urodynamics with our relevance. Okay, there are other indications like neurogenic and all these things, but these are not for our relevance. Okay, now what are the prerequisites? So prerequisites before doing urodynamics is you should know for exactly what you are going to do this urodynamics. So you have to form a clear diagnostic question. So you should know for what you are going to do urodynamics. It's not only for lower urinary. Some urinary dysfunction is there, and for that you will do just like that urodynamics. No, you have to formulate a proper diagnostic question. You should know for what exactly you are doing. Okay. Then you have to take a comprehensive history. You have to see the medication list. Okay, what medication she is on. You have to do urine analysis because you have to rule out any infection. In presence of infection, you can't do urodynamics. Okay, you have to do clinical examination because you have to see whether she is having any problems like prolapse or any pelvic masses. Okay, also you have to complete the bladder diary for 3 days. Hmm? And valid bother score and quality of life questionnaires. Now, for every incontinence and prolapse, this questionnaire, quality of life questionnaire, are very important before doing any surgical management. Okay, and an abdominal and pelvic examination, assessment for prolapse, vaginal wall, and pelvic masses, genital atrophy, pelvic muscle quality and contractility, that is tone. Okay, and urinary leakage, if it is there or not, whether the leak is there or not, and focus neurological examination to find out any causes of neurological bladder. Okay, so all these are prerequisites before doing urodynamics. Now you have to take consent. So while taking consent, you should remember that this test will cause significant anxiety, embarrassment, and discomfort for the patient. Okay, so clinician should be very sensitive and should treat the patient with respect, and you should allow adequate privacy and adequate time. Otherwise, the results may be wrong. Okay, I will explain you exactly what happens if the privacy is not there afterwards. Okay, it is advisable to provide written information and to explain the test before their arrival, so they will know exactly what they are what to expect during this test. Or otherwise, if they suddenly arrive for the urodynamics and then you are asking them to void in presence of you, then it will be very embarrassing for them. Okay, so for that you should exactly inform them exactly what is to be done in that test. Okay, now what are the limitations of this urodynamic studies? It has there is lack of predictive value of urodynamic observation on their chance of cure. So after surgery, whether the condition will improve or not, urodynamics can't tell regarding that. Okay. Even there is unreliability in predicting adverse outcomes of surgery. So for treatment point of view, it has got no advantages. Okay, it is only a diagnostic test. There is no therapeutic effect and it can't predict any treatment outcomes. Okay, even if the diagnosis is correct, it can't predict any treatment outcomes. Okay, so clear till now?
Yes, ma'am.
Yeah, so now how you are going to prepare the patient for urodynamics? So in this, first is you have to stop. Previously, it was like that you have to stop the antimuscarinics prior to urodynamics. Okay, but now the latest recommendation suggests that it depends upon the clinician whether to stop or not stop. Okay, but if you are if the patient is on antimuscarinic, while performing the urodynamics, you should make a note of it, okay? And they are clearly documented in the report. Urinary dipstick must be checked. So it is a must prerequisite that you should do urine dipstick for infection and hematuria. And in the evidence of an infection, then the urodynamics should be postponed until the infection is cured, okay? Strict asepsis should be maintained while during this urodynamics. If there is any evidence of prolapse, then it should be reduced either using a pessary or speculum or finger. Okay, so prolapse should be reduced to see while during the while doing this urodynamic test. Okay, so see, this is the urodynamics. This is the machine, or this is the setup for this urodynamic study. So can you see this chair? So this is a chair. So whenever the patient comes first, the patient is asked to sit on this chair and void. Okay. So for this, it requires a privacy, because if the privacy is not provided, the patient may feel embarrassed and she may not void completely, or she may void intermittently. Okay, because when you ask patient to void in it, and you see this small jug is there, it has got usually a rotating flow meter, so it will count the flow also. So flow rate it will count, and it will count the volume also. Okay, and after this voiding, you are going to measure a post-voidal residue by scan, or by ultrasound, or by inserting a catheter, and then you will be doing the pressure studies. Okay, so I will tell you in detail exactly what you are going to do, but this is the setup for this urodynamics. Okay. So what are the components of this urodynamic study? So first part is representative uroflowmetry with post-voidal residue. So that's what I told now. So first patient is asked to void on that machine, that is uroflowmetry. It is a rotating flow meter will be there, and patient is asked to void on that, and after that PVR will be measured. Then transurethral cystometry. So transurethral cystometry means by through urethra you are going to insert the catheter, and you are going to insert see the pressure changes in the bladder, and also pressure flow studies in the bladder, and the abdominal changes and diastolic pressure changes that you are going to measure. So these are the three components of the urodynamics. Okay. So what exactly you are going to do in the uroflowmetry? So here the patient is asked to void by relaxing, not straining. Remember, well, not straining. And while sitting on a commode over a rotating disc flow meter, or weight transducer flow meter. Okay. The volume of urine passed per unit time can be assessed in ml per second. Okay, in mil per second, giving a maximal flow rate and volume voided that can be displayed graphically. So this voided volume, it will be displayed graphically. I will show you after this exactly what it means. Then post-voidal urine volume can be measured either by ultrasound or with a catheter. Now this shape of the flow curve which is obtained, it can be analyzed to provide the insight to whether the patient is emptying the bladder normally, or any voiding dysfunction is there. Okay. So what is the normal flow curve? It is a bell shape. So bell shape means it has a rapid upstroke, a curve with a continuous flow, and uh, that curve will have a continuous flow and clear maximum flow rate, and quick decline to end cleanly. This bell or arc is not symmetrical. Okay. So yes, can you see, this is the bell shaped curve, but it is not symmetrical. It is not a proper bell shape, but it is a representative bell shaped curve, and this is the volume. Okay, this is the volume. So this is the typical bell shaped curve. Here you can see the normal flow with the volume voided is around 250 ml. Okay, so can you see, this is the volume voided is 250 ml. So this is the Uroflowmetry. So here, see, this privacy is very important so that you will get a proper voiding curve. Okay. So now, if there is any problem in the voiding, if there is any voiding dysfunction, so what you are getting? So you can get several peaks in Q marks. Instead of this bell-shaped curve, you will get several peaks. So what will happen exactly? So it can be due to repeated valsalva, okay, or repeated straining, which can leading to fluctuating and intermittent stream, okay. And in which condition this occurs? This occurs in bladder outflow obstruction. Bladder outflow obstruction from inside, not from outside, and unsustained detrusor contraction, okay. So in that cases, it will this graph will give like this several peaks. Now there is reduced flow. Reduced flow rate can be there. So what will happen there is rapid upstroke is there, but the flow rate will not cross the 15 ml per second. So normal flow rate is around 15 ml per second. So it will not cross the 15 ml, okay, but it will the Qmax will be reduced and it will give a plateau shape. So in which condition it can occur? It is a urethral. It can be either because of urethral stricture or because of some external compression or bladder outflow obstruction. That is from outside, like prolapse or continence surgery, okay, or a contractile detrusor. So in case of hypocontractile bladder, when the detrusor contraction is not sufficient, then also you can get this type of graph. Then sometimes a single very small curve, very small means the height of the curve will be more, but the duration will be very small. So in that, rapid upstroke and downstroke will be there. So it can be due to detrusor overactivity or high speed squatting to overcome any small obstruction. So very high Qmax can be seen here. In next example, you can see this. So what are the causes? 1 minute. So what are the causes of this voiding dysfunction? It can be due to detrusor contractility dysfunction, any urethral dysfunction, or bladder outflow obstruction. Okay, and now there is one term known as suprapubic tapping. So when you tap suprapubic area, it will cause a short bladder contraction, and when it is combined with straining, it will cause a partial emptying of the bladder, and usually there will be high PVR. So what is the significance of it is, it is seen in neurological disease, okay. So there is not much given in that talk or anywhere regarding the suprapubic tapping. So for you, this is the only thing relevant, okay. So this, if you know this, this is sufficient, okay. Now PVR less than 100 ml. So now PVR for post-viral residues, they have given different values. Exactly which value is correct, we don't know, but it is between 50 to 100. So PVR less than 100 is not regarded as clinically significant. Somewhere they have given it as 50, somewhere they have given it 100, and somewhere they have given it when it is more than 150, it is significant. So I don't think anybody will ask you what is the significant PVR. So high PVR may be due to detrusor underactivity caused by anticholinergic medications. So that's why you should know exactly which medication the patient is on. Okay, so that you will know if this is the voiding dysfunction is because of this anticholinergic medication or because of her some problem because of any outlet obstruction or detrusor failure. So for that you should know the medication history. Now cystometry. So once this flowmetry, uroflowmetry is over, the second part of the urodynamics is cystometry. So exactly what is cystometry? It will assess the bladder storage ability. So what it involves is, it involves artificial and continuous filling of bladder with fluid via a single lumen or double lumen catheter. So single lumen catheter, it will only fill the bladder, but when there is a double lumen catheter, it can also measure the intravesical pressure. Okay. So normal values of this pre-vesical is 5 to 50 centimeters of water. Now there is another catheter that where we have to measure the abdominal pressure also. So abdominal pressure is usually measured by rectal catheter. Okay. So it may be a fluid filled catheter or air catheter. It is used to measure the pressure surrounding the bladder or abdominal pressure. So abdominal pressure is usually measured from the rectum. So International Continence Society, what it recommends is abdominal pressure should be measured by the rectal catheter only. But if it is impossible, then abdominal pressure can be measured through a catheter in vagina or a stoma. Like if any colostomy is there, then you can measure it from that stoma or from vagina. Now you have to know three pressures for this cystometry. One is the vesical pressure that you are going to measure by inserting a catheter inside the bladder. Abdominal pressure by inserting a catheter into the rectum. So now the third pressure is there, that is detrusor pressure. So detrusor pressure, how you are going to measure? So there is no any direct measurement for detrusor pressure, but it is usually achieved by subtracting the abdominal pressure from vesical pressure. And the machine will do the calculations. You don't have to do. The machine will do the calculation and it will produce a graph. Okay. So detrusor pressure, this is a SBA. Remember well, detrusor pressure is derived by subtracting abdominal pressure from vesical pressure. Yes, any doubts? Any doubts, Jasmine? Okay. So yes, this is the diagrammatic representation of exactly what I was telling now. So see, this is the bladder. There are these two catheters. This blue line here, you are filling the bladder with normal saline. Okay. This black line in the bladder, it represents the pressure in the bladder. Okay. So it is measured by a catheter inside, pressure transducer inserted inside the bladder. Okay. This is the third line. It measures the abdominal pressure by a catheter or transducer that is inserted in the rectum. And yes, with this catheter, when you, after this filling cystometry, again there will be a voiding place. Here you are going to measure again the flow. So there are two types of graph on this urodynamics. So one is the filling graph and one is the voiding graph. So there are two graphs. So whenever interpreting any urodynamic graph, you have to see whether the filling phase is there or voiding phase is given in that graph or both phases are given. Okay. So while reading, it is important which phase you are reading, whether you are reading a filling phase or voiding phase or you are reading the graph of both phases. So how you're going to record this now? Cystometry. So first resting pressures of abdominal and bladder pressure should be recorded at the beginning of the cystometry. So in that, after that, the bladder it should be continuously filled with normal saline at room temperature. Okay. So how you are going to fill this bladder at which rate? So ideal filling rate should be 10% of the maximum voided volume. Okay. So if it is a 500 ml, then 50 ml per 50 ml per minute should be the rate. But usually a patient with detrusor overactivity may need a slower rate of 10 ml per minute. Okay. So because you have to achieve a balance between the physiological feeling and the time you will be spending in the clinic for this feeling of the bladder for the test. So for that you have to maintain a balance. So usually around 25 to 50 ml per minute should be used for the feeling phase because the physiological feeling of bladder is at 1 to 2 ml per minute. It should not be very fast. It should not be very slow also. Okay. Now what you will be recording. So once you have started feeling the bladder, you have to ask the patient. Okay. So first you will be recording first sensation of bladder feeling, like when she feels that, when the moment the patient feels that the bladder is no longer empty. Okay. Then what your next thing is first desire to void. So the moment that normally tells the patient to go to the toilet without any hurry at the next convenient moment. So there is no urge, but the patient feels that yes, she can void if if the situation is permits. Okay, so it is a first desire to void. Now the next thing is strong desire to void. So it is equal to the maximum capacity, maximum bladder capacity. So it is the moment when the patient feels that without any fear or any fear of leaking, she should not postpone the voiding and she should visit the nearest toilet. Okay. So this is the strong desire to void. Any feeling of urgency, any fear of leaking or pain, that all should be recorded. Also during the feeling phase, the patient is asked to cough every minute to assess the recording quality. Because during cough, there should be rise in the vesical pressure and abdominal pressure, and the rise should be equal, and there should be no rise in detrusor pressure. If these three things are there, then you can say that yes, your transducers are working properly, your pressure catheters are working properly, and your recording is going on smoothly. Okay, so this is the check. If a patient is asked to cough every minute, and you have to check whether there is equal and acute rise in the abdominal and vesical pressure, but there is no rise in the detrusor pressure. Okay, and then you have to ask the patient to do some provocation maneuvers. So to assess the patient's symptoms, whether she is getting any urgency. So which provocation maneuvers you have to ask the patient to do this? Hill bouncing, jogging, listening to running water, washing hands, coughing, or refilling the bladder in various positions, or cool medium. So, and when you are performing any of these provocation tests, they should be annotated on the cystometrogram. Okay. So, with this provocation test, if the patient is getting any symptoms, okay, then you can diagnose the problem. So now, what are these normal parameters? So residual urine. See, now you can here see this PVR here. They have given it should be less than 50 ml. In the same talk, they have given another value of 100 ml. So these different values are given for PVR. So, and it is from 50 to 150. Okay, in different guidelines and different talk articles. So there is no consistent value for normal PVR. First desired void is between 150 to 200 ml. Bladder capacity is between 400 to 600 ml. Detrusor pressure rise is less than, remember this well, the detrusor pressure rise should be less than 15, okay, during feeling and standing pressure. So this is very important. Detrusor pressure should not rise more than 15. There should be no systolic contraction, detrusor contraction. Okay, also there should be no detrusor contractions on any provocation maneuver. There should be no leakage on coughing, and the voiding detrusor pressure should be less than 70. And during voiding, the flow rate should be more than 15 ml per second, and at least volume should be 150 ml. So when this voiding volume is more than 150 ml, then only there is any meaning for this peak flow rate and detrusor pressure rise. If the volume is less than 150 ml, you can't interpret any voiding graph. Okay. So remember that for interpreting any voiding graph, the voided volume should be more than 150 ml, and during voiding phase, detrusor pressure should be less than 70, and flow rate should be more than 15 ml per second. Clear now for these values?
Yes, ma'am.
These values are very important.
Um,
Yes.
Excuse me, ma'am. Is this residual volume post-voidal residual volume less than 50 or 100?
That's what I'm
What is the
telling.
normal value?
That's why I'm telling now. They have given different values everywhere. Okay, so we can't follow any value that is normal. They have given different readings from 50 to 150 as normal. Okay, in different guidelines and different talks. Here only in this talk they have changed the volume values 2 times. Okay.
Okay.
So
Okay.
and they have mentioned also nowhere it has been given any proper value for PVR. Okay, they have mentioned that also. So we can't tell any exact value for this PVR, but it should be between. They have given the different values from 50 to 150. So now whenever you get any graph, urodynamics graph, so how you are going to interpret? So first check, what you have to first check is whether it is a feeling study or voiding study or both. Okay. So what you have to interpret, whether a feeling graph or voiding graph you have to interpret, or they have given both graphs. Okay. Now then you have to see at the initial whether the pressures are zeroed or not. Okay. Then you have to see during the cough impulse whether there is a simultaneous rise of abdominal and vesical pressure is there or not, and when there is during cough any leak is present or not. Okay. So when there is an increase in the vesical and abdominal pressure along with leak, then it is known as urodynamic stress incontinence. So when stress incontinence, when it is demonstrated on urodynamic graph, it is known as urodynamic stress incontinence, not only SI. Okay. So this is a terminology for that SI. Okay. So there should be increase in the abdominal pressure, increase in the vesical pressure along with leak. and detrusor pressure should not rise. Now, when there is increase in the vesical pressure along with detrusor pressure, it is known as detrusor overactivity. So, for urgency symptoms, the urodynamic name for that is detrusor overactivity. Okay, and when this detrusor overactivity, when it is present along with leak, it is known as DO with incontinence. That is detrusor overactivity with incontinence. If there is increase in vesical pressure, detrusor pressure, and along with sensation of urgency, not leak, but it is a urgency sensation, then it is known as DO with sensory urgency. Okay, then we have to see all this. Along that, we have to see for any artifacts, and if voiding phase is present, we have to see for any voiding dysfunction. So all these things we have to see while interpreting any urodynamic graph. So we will do it on one normal graph so that we can understand. So this is the normal urodynamic study. So can you see this blue line is a vesical pressure, that is bladder pressure. Red line is the abdominal pressure. Green line is detrusor pressure. Okay. Then last two columns are volume and flow. Okay. So now first you see whether both graphs are there or not. So this is the, can you see this line? This dotted line, three dotted lines are there. So can you see this line? So this is the difference between the filling and voiding line. So see, you can see both the graphs are there. Filling also is there and voiding is also they have given. Okay. Now, after this, we have to see whether the pressures are zeroed or not. So can you see here the pressures are zeroed at the start. Okay. Then we have to see actually volume. They have not given any graph for the filling phase. They should have given some graph for filling phase. Usually the graph will be there for volume. Okay. That filling phase, the graph should be there. Okay. So in what rate the bladder was filling. Next thing is during cough. Can you see these are the cough impulse? Intermittently, these are the patient is asked to cough, and during that cough, there is acute rise in both vesical and abdominal pressure, but there is no rise in detrusor pressure. Can you see this? So that means this urodynamic, this pressure recording is going on normally. Okay, it is going on smoothly without any problem in the transducers. Okay. Now see, this is the first sensation. So first sensation of void now. Okay, first sensation of void she has got at 172 ml. Strong urge to void she has got at 519 ml. So capacity of bladder is 519 ml. And then this is the voiding graph. Now, can you see this is the flow? There is no leak at all. Okay, no any leak is observed during the filling phase. Okay. And there is no increase in any detrusor pressure. So that means filling phase is absolutely normal in this graph. Now, when you will see this voiding graph, can you see the vesical pressure rises there? There is no abdominal rise. The abdominal pressure, there is no rise. Detrusor pressure rises maximum 54 centimeters. Oh, 54 centimeters of water. It should be less than 70. So it is a 54. That means it is normal. Volume voided is 519 ml. And this is the graph, bell-shaped graph, and the maximum flow rate is 17 ml per second. So it is this voiding graph is also normal. So okay, got
Yes,
it? What is the normal graph? Both filling and
yes,
voiding.
ma'am.
Filling is normal, voiding is normal. Got it?
Yes, ma'am.
Yeah. Yes. So now this is another graph. Now can you tell me whether here voiding phase is there or not? Which phase is there? Are there any both phases or single phase?
Single
Filling
phase.
phase only.
Yeah, it is only filling phase. There is no voiding phase. Okay. Can you see this graph? So this is the, so first while interpreting any graph, first see whether it has got both phases or any single phase. So here they have given only single filling phase. Okay. And how you are going to know that? You have to know the volume. Okay. If the volume they have shown, voided volume they have showed, that means it is a voided phase. Okay. So can you see now? See, this is the vesical pressure. This is the abdominal pressure and this is the detrusor pressure. Pressures are zeroed at the initial. With cough reflux, there is increase in the abdominal and vesical pressure, but no increase in the detrusor pressure. Okay, so that means the recording graph recording is normally going on. Okay, there is no problem with the recording. Now, can you see when there is increase in the vesical pressure, there is increase in the detrusor pressure also, and some leak is observed. This black flow you can see, so there is some leak. So it is a detrusor overactivity with incontinence. The diagnosis here is detrusor overactivity with incontinence. So if this leak is not there, it will be only detrusor overactivity. Clear this graph?
Yes, ma'am.
Okay, we'll go to the next. Okay, yes. So now, yeah, is the only single phase or both phases?
Both phase.
Yes.
Both phases.
Yes. Okay. Whether the pressures are zeroed or not? Yes. Okay.
Yes, ma'am.
Yeah.
Yeah.
So whether there is any with any cough impulse, the rise in the vesical and abdominal pressure is there or not? Yes, it is there.
Yes.
Okay. But there is no rise in the detrusor pressure. That means the recording is normal. Okay. Now the next, see, EMG part is not for us. Okay. Sometimes the EMG is also recorded, but it is not for us to interpret. Okay. It is for any neurogenic causes. So now in the feeling phase, can you see any problem? There is no any detrusor overactivity seen. No leak is seen. See, this flow is there. There is no leak is seen. Okay. So all feeling phase is normal here. Agree with me?
Yes, ma'am.
Yes, ma'am.
Okay. Now,
Yes, ma'am.
yes, good. Now voiding phase. Now voiding phase, can you see the detrusor pressure? Now they have not given any values. I think it must be 78 or 84 for these things. I don't know exactly what they have given, but they have not given any values, so we can't comment on that detrusor pressure rise. Okay, because they have not given any values for that. But yes, can you see this voided graph? What do you think it is? Whether it is a normal thing?
Peak flow rate is
No.
reduced.
Yeah, it is reduced. It is reduced and it is plateaued. Correct?
Yes, ma'am.
Yes.
It is
Outlet.
plateaued. There are no spikes. No spikes with straining or something like that. So what is the reason here is most probably it is a outlet
Obstruction.
obstruction, and because of some outside obstruction. Okay, inside obstruction will give rise to peaks. Okay, so outlet obstruction because of stone or any mass inside, it will give rise to peaks. It is whether it is when it is from outside, it will give rise to this plateaued graph with reduced Q max. Okay, so this is the bladder outflow obstruction. And why bladder outflow obstruction? Why not hypocontractile bladder? Why not because of detrusor underactivity? Because you can see this detrusor pressure is rising normally, correct? There is no problem with the detrusor pressure rising. Okay, so that means detrusor activity is normal, but still flow rate is reduced. That means there is some obstruction. Even the volume voided is also less, correct? So there is some bladder outlet obstruction is the cause. Clear? Clear with this graph?
Yes, ma'am.
Yeah. Thank you. Yes.
Hello?
Yes. Yeah.
How
Yes. Yes. Who is that? Yes. Who was that?
how are you?
Yes. Zaran. Yeah.
I know this is how I know this is the filling phase or voiding phase.
Okay. How you will know this
Yes.
is feeding or voiding?
Yeah.
So, yeah. Can you see this graph? Okay. Can you see in the small letters they have given this VO, VO, VO? Did you
Yes.
got it? The small letters VO, VO, VO they are given. So that means it is
Yes.
void, and this is
Yes.
peak. That means it is post void. Got it? Yes. Clear?
Yes. Yes.
Yeah.
Okay. Thank you.
Okay.
Ma'am, is this the type of plateau type of urethral stricture sort of thing that he told?
Urethral stricture will give rise to spikes. Okay.
Spikes with blood. Okay.
Yes.
Okay, ma'am.
Yeah. Yes. Now this graph. So whether this is the filling or voiding phase?
Feeling.
Yeah. Can you
Filling
see
phase.
this infusion is there and it is going on increasing. So that is filling phase. Okay. Now yes. Whether the pressures were zeroed? Yes.
Yes.
Now can you see here during the cough impulse there is rise in the vesical pressure along with rise in abdominal pressure. Now here clearly they have mentioned there is a leak. Okay. So with these two things there is a leak is observed. Got it? They have clearly written this here because they have not given any. See, this is the flow. Okay. Can you see this? This is there is leak, there is leak, there is leak. 3 leaks are there. Got it?
Yes, ma'am.
Yeah. So diagnosis.
Stress incontinence, ma'am.
Stress urethral.
Yeah. Not
Urodynamic stress
stress.
incontinence.
Urodynamic stress incontinence. Yeah.
HUI.
Yes. Urodynamic SUI. Yes. Okay. Now again this graph. One phase or both phase?
Both phases.
Yes. Very good. Pressures are zeroed. Almost near to zeroed. Okay. Yeah. With cough, there is rise in the abdominal and vesical pressure simultaneously. That means recording is normal. Any leak is there? Yeah. See, can you see here small
Yes.
leak is there? Got it?
Yes, ma'am.
With cough, leak is there. Okay. So this is urodynamic stress incontinence.
No, stress incontinence.
So this is filling phase. Now in voiding phase, did it cross 15? No. So that means reduced flow rate is there. Correct?
Yes.
Detrusor pressure has risen to more than 70. It has reached almost 90, correct? 90 to 100. So detrusor, sorry, here. So here detrusor pressure, yeah, it is okay. It is from 70 to 75 only. So this is normal only, okay? So detrusor pressure rise is normal, but reduced Qmax is there. So here also can be some external obstruction. Again, the plateau phase is there. The bell shape is not normal. It is plateaued, okay? So here also can be there is some obstruction. Got it?
Yes, ma'am.
Yeah. So in the filling phase, it is urodynamic stress incontinence. In the voiding phase, there is some bladder outlet obstruction. Okay. Now, how you are going to identify any artifacts? So what are the artifacts? They are spurious or inaccurate measurements that can lead to failure of reproduction of symptoms or any false negative or false positive findings. So where did these artifacts arise? So during uroflowmetry, it can be due to patient movement or rapid abdominal straining. Okay. During cystometry, it usually occurs as a result of equipment setup, patient positioning, or catheter properties. And in pressure flow studies, artifacts are usually caused by displaced pressure transducers, which can be picked up with cuffing before and after voiding and therefore corrected. So what we are going to do usually, what we are going to do with cuff check is whether these transducers are in correct place or not and whether the pressure is recorded correctly or not. That's what we are going to see in the pressure flow studies. Okay. In the uroflowmetry, how we are going to avoid these artifacts? So we are going to give the patient adequate privacy. We are going to tell the patient that do not strain, okay? Void at your convenience, okay? And in the cystometry, we have to adjust the equipment. We have to see the equipment, it is working during the procedure properly or not, okay? So, yes, initial quality checks. How to avoid artifacts is initial quality checks and set up with calibration. So, calibration should be done before you start the procedure. Then you have to continuous check and correct the calibration. You have to see the pressure transmissions, catheter patency and locations and patient position throughout the procedure. Privacy can help to reduce the artifacts in uroflowmetry, as can checking with the patient that they have had a representative void. So that means whether we have to ask whether they have voided normally or not. Cuff pressure leaks should be seen throughout the study, and zeroing transducer to atmospheric pressure and expulsion of any air bubbles. So air bubbles is also an important cause for artifacts. So here this is the graph. Can you see this is the continuous movement of this vesicle pressure? Okay, so these are the artifacts, and why it has occurred? Because of the pressure catheter and the feeling catheter in the bladder, they have overridden. Okay, and because of the saline is moving through this feeling catheter, no, it has causing these pressure changes on this pressure transducer. Got it? So this artifact is because of that. Got it?
Yes, ma'am.
Yeah. So this was everything about the urodynamics. Simple urodynamics. Okay. Now, what are the other tests which are also can be done for this diagnosis of this lower urinary tract dysfunction? Is the PAD test, video cystometry, ambulatory urodynamics, and urethral pressure profile studies. Okay, of this, only 2 are recommended by NICE. That is video cystometry and ambulatory urodynamics. This PAD test and urethral pressure profiles are not recommended by NICE. Okay. So what is this PAD test? They have given it in very detail in the talk. That's why I'm describing it. So it is performed to detect and quantify severity of urine loss if urodynamic observations are not accepted by the patient. So patient is not ready to do the urodynamic studies, or if urodynamics have not produced the results explaining the patient's symptoms. Usually, but they will not give any diagnostic cause for the urinary incontinence. Usually, it is a short-term test over 1 hour, which involves wearing a pre-weighted pad. So first you have to give a pad to the patient, which has been weighed previously, and then ask the patient to exercise for 30 minutes. And before and after weight of the pads will determine whether the leakage is there. Okay, and usually most accurate if based on a fixed bladder volume. So positive test is weight change more than 1 gram. See, it is 1 gram. Okay, if there is any change more than 1 gram, it is a positive pad test. It is during a 1 hour, patient is asked to exercise for 30 minutes and weight change is observed. In the long-term test, usually patient is asked to go home. Over 24 to 48 hours, it will be measured, and we will ask patient to do normal activities wearing a pre-weighted pad. And then we have to see whether this pad test also, short-term pad test also has not given any result. Then we can ask the patient to do this test at her home. The pad is changed every 4 to 6 hours, and it is weighted either immediately or store it in an airtight bag. So weight gain more than 1.3 gram is a positive result. So I don't think anybody will ask this, but only thing is remember, for short-term test, weight gain more than 1 gram is a positive test. For a long-term test, weight gain more than 1.3 gram is a positive test. Okay. Now what is video cystometry? So video cystometry is performed using a iodine-based contrast to allow X-ray or ultrasound imaging. Okay. So what you are doing, you are going to do a normal urodynamic graph, and along with you are going to take some X-rays along with some contrast medium injections. Okay. So what is the risk of this is any allergy to the contrast medium or radiation exposure. So these two are the disadvantages: allergy to any contrast medium and radiation exposure. So it is not done routinely, but it allows visualization of this functional anatomy of any lower urinary tract. Okay, so if any functional problems are suspected, you can do this video urodynamics. This can lead to more comprehensive assessment in children, suspected multifactorial etiologies, and in patients with neurogenic bladder. In our cases, it is usually useful in identifying any vesico-ureteric reflux or also correlating with SUI. It also allows detrusor sphincter dyssynergia, bladder or urethral diverticula or fistula, and bladder herniation. So any anatomic abnormalities can be visualized very well with this video cystometry. So yes, can you see? See, this is the graph which is given in this talk article. This thing can come in your paper as a question, because usually they give the images in the talks or strategy, okay, as a question. So this can be a SBA. Can you see? This is the video urodynamics. Here, can you see this outpouching of the bladder mucosa? 1, 2, and 3. So this is the bladder diverticula. Diagnosis here is a bladder diverticula. It is the outpouching of the normally smooth bladder wall is delineated with the contrast medium. So such things can come in your question paper, okay? Because they usually give this TOG and strategy images. Now, what is ambulatory urodynamic monitoring? It is useful if the conventional urodynamic observation failed to reproduce or explain patient symptoms, because it will allow physiological feeding of the bladder, and it allows the privacy. It is usually done outside the artificial clinic settings. So usually it is done at home, and it allows the day-to-day activities, a patient to do the day-to-day activities that may provoke the incontinence symptoms. Okay, so it is easy to reproduce at their home settings with the normal day-to-day activities. Now, urethral function test, how you are going to assess this urethral function test? So this can be assessed during feeling cystometry and voiding. Usually these are not recommended in isolation to assess the patients because of poor sensitivity and specificity. But usually urethral pressure flow profilometry assess the urethral ability to maintain a closed bladder outlet. So we have to see if there is any urethral hypermobility, any urethral intrinsic sphincter deficiency. We have to see the exact cause. Then we can do the urethral pressure studies. Okay. What it records is the absolute urethral length, functional urethral length, and maximal urethral pressure and maximal urethral closure pressure. So when in SUI, in SUI, what we are going to tell the etiology of SUI is either because of urethral hypermobility or because of intrinsic sphincter deficiency. So these two things, if you want to differentiate, the urethral pressure flow studies are very good for this, to differentiating in this. So what we are going to do in this is a catheter will be placed in the urethra and withdrawn along the length of the urethra, and this measurement produces a graph of the intramural pressure of the urethra. Okay, but the clinical relevance is not yet clear because they have been shown to have significant test-retest variations. So very significant variations have been obtained. So clinical significance is not yet clear. It is therefore recommended to only perform this test in addition to standard urodynamic observation if deemed necessary. Okay. So this last sentence is very important. It should not be done in isolation. Okay. So this completes the urodynamics. Anybody has any questions? Clear? We will do the questions at the end of these two things. Okay. Okay. So no doubt we will go to the POPQ classification now. So what is this POPQ? Is pelvic organ prolapse quantification system. What are the advantages of this is it is internationally accepted. It is objective assessment, so there are no inter-observer variation. It is valid for research purpose also, and it is used to quantify the surgical outcomes also. Okay, so these are the advantages because it is not subjective but objective assessment. We are going to measure it. Okay. So how you're going to measure this POPQ? We have to ask the patient to strain maximally. So we can do it either in Valsalva position. We can give the traction on the prolapse and measure it. And we have to confirm it by the patient that it is the maximum prolapse, or we can do it in the standing. Okay. So how this works is, here is the hymen is the selected as the reference point. Basic reference point is the hymen. Okay. Rather than introitus, because it is a precisely identified point, hymen. And this terminology avoids assigning a specific label. So it is not going to tell you whether it is a cystocele, rectocele. You are not going to define the prolapse like cystocele, rectocele, okay? But we are going to define the prolapse compartment wise, okay? Whether it is anterior or posterior compartment, okay? So what are these 9 points? So this grid you have to remember very well. So anterior wall there are 2 points. Posterior wall there are 2 points. In the apical there are 2 points. And then in the on the introitus there are 2 points. And the last point is total vaginal length. So there are total 9 points. On the anterior wall 2 points are AA and BA. Posterior wall there are 2 points AP and BP. Apical region there are 2 points, that is C and D, okay? And then there are 2 points, that is genital hiatus and perineal body. In relation to this thing introitus, we are going to define these 2 points, and then we are going to calculate the total vaginal length also, okay? So now we are going to how to measure this all the points. So when the prolapse is reduced, we have to measure 3 things, remember well. In reduced prolapse, we have to measure 3 things, that is genital hiatus, perineal body, and total vaginal length we will be doing with reduced prolapse. Now see, they have given here mark 2 points, not measure. So what we are going to do, we have to mark the points AA and AP. So what is this AA and AP point is? AA point is 3 centimeter proximal to the hymen on anterior vaginal wall. And AP is the 3 centimeter proximal to hymen on posterior vaginal wall. Okay, so we have to mark these 2 points with the reduced prolapse, and then we have to measure these 2 points when the prolapse is maximum. So we are not going to measure AA and AP with reduced prolapse, but we have to measure it with maximum prolapse. Only we have to mark it, because unless we mark it, we mark those points, we can't measure those points, because we have to mark it exactly 3 centimeters proximal to hymen. Clear this point? This point is very important, that we are not going to measure this point with reduced prolapse, but only we are going to mark these points. Got it?
Yes, ma'am.
Yeah. Now with maximum prolapse, we will going to measure these points like AA, AP, BA, BP, C and D. We are going to measure all the points with hymen as the reference. So we will be doing AP, BP, C, D, AA and BA. So all the points we are going to measure with the hymen as the reference point. Okay? Got it?
Yes, ma'am.
So now after measuring this, we have to stage this POPQ. Okay? So how we are going to stage this? It is the stage 0. What is stage 0? It is from stage 0 to stage 4. So stage 0 is the normal position of all the organs. So exactly what it corresponds is, so AA, as I told you, it is a 3 centimeters proximal. AP, it is a 3 centimeter proximal to hymen. So it is a -3, -3. Also BA and BP will be -3. So above the hymen it will be minus, below the hymen it will be plus, at hymen it will be 0 measurement. Okay. So measurement at the hymen it is 0. Below the hymen in the plus. Below the hymen it is plus. Above the hymen it is minus measurement. Okay. So when you call it a stage 0, AA, AP, BA and BP all are at -3. C and D will be, so like when you are doing, what is here, X is total vaginal length. So total vaginal length, when you are measuring this total vaginal length, so C and D point will be at less than or equal to total vaginal length -2. So what does it mean? So if you measure the total vaginal length as 9 centimeter, okay? If the total vaginal length is 9 centimeter, then C and D should be at the level of -7 or -8. So -7 will be also included in the stage 0. Clear it? Clear? See, this staging is very important. So when the total vaginal length is, you suppose it depends upon the total vaginal length. So if total vaginal length is 9, C and D should be at 7 or above. So -7, -8, -9. Okay. So this will become stage 0. Clear?
Yes.
Clear or not?
Yes, ma'am.
Yeah.
Yes, ma'am. Yes, ma'am.
So now stage 1. So all these things are related to the PVL. Remember that. So now stage 1, it is when I'm telling where the total vaginal length is 9 centimeter. So anything more than -7. Okay. So that means -6, -5 up to -1 will be stage 1. So when the criteria for stage 0 are not there and leading edges prolapse is less than -1. So above -1 and below stage 0, it will be stage 1. So for 9 centimeter vaginal length, it will be between -1 to -7. Clear? So it will be from -2 to -6. It will be stage 1 prolapse. Got it?
Yes, ma'am.
Yeah. So now stage 2. Stage 2 is
Can you just repeat this, Dr. Mridula, please?
yeah. See, stage 1, I'm telling you with the reference of total vaginal length, and always staging should be done with the reference of total vaginal length. So now suppose that total vaginal length is 9 centimeter. So here your cervix or D, that is posterior fornix, it will be when it is less than -7, that is -7, -8, -9, it will be stage 0. When it is more than -7, that is -6, that is from -1 to -7, it will be stage 1. Got it?
-1 to
-7. -7, how I
-7.
got it? If it is 9. If it is 10, it will be -8.
Yeah,
Okay?
7.
Yeah.
It
Okay.
will be -7. If suppose this TVL is 9,
It will be
it will be
-7.
-7.
Yeah.
So
If
it will be stage 0. So how do we calculate this -6 and -1?
you have to calculate
Stage,
this exact. Now I will tell you with
whatever will be
examples.
the TVL, right?
Yeah. So depending upon the TVL,
-2.
yeah, TVL -2.
Okay.
Got it? Still confusion.
So,
Okay, we
so
will.
if it is suppose it is total TVL is this 7. So
Okay.
7 minus 2 will be 5. So it will
Yeah.
be -5, right?
Yeah.
So
-1
what
to
will be the
-5. -1 to -5 will be stage 1. -5 and above will be
-5.
stage 0.
Up to -1, less than -1, it will be stage 1, right?
Yeah.
Whatever value it is.
Whatever value is. Okay.
Yeah, correct.
Yeah. Stage 2, it is very easy. From -1 to +1. -1, 0, +1. It becomes stage 2. Any calculations, any measurement from -1 to +1 becomes stage 2. Again, stage 3, +1 to TVL -2. So it mirrors stage 1. It is the same mirror of stage 1. Got it?
Yeah, but outside.
Yeah, outside. And stage 4, it is a mirror of stage 0. Outside. Got it?
Yes.
We will do it
Yes,
with
ma'am.
examples so that you will come to know better. You will know it better. Okay? I will tell you exactly with the examples. Yes. Now can you see this? So here, see, C point is cervix, D point is posterior fornix. AA, BA, AP, BP. So this is the normal position of the uterus. Okay? In this normal position, what are the values? So AA and BA both will be at -3, -3. AP and BP both will be at -3, -3. Here TBL, suppose it is 10. So C point is -8.
10 minus 2. 8.
Okay? It can be 10 minus 1 also. It can be at 9 also. Depending upon the cervical length, it will be. Correct? But it should be at least 8. Okay? For stage 0. And D posterior fornix is corresponding to the total cervical total vaginal length. Okay? So this is the normal position of the uterus and all these things when it is a stage 0 prolapse. Now, can you see? Now here, Can you tell me whether it is a normal prolapse or vault prolapse?
It's a
No,
wall
it is a
prolapse.
normal.
Prolapse.
C is there, no?
C
So it
is
is not
there.
a.
Yes.
C
So
is
it is not vault.
no. C is
No, D is not there.
yeah.
D is not
is
there.
not
D is
there.
absent. Yes, yes. Post hysterectomy.
Yeah, there will be no posterior fornix in the vault prolapse. Vault is correspond to the C. Okay, vault scar
Right,
will
right.
correspond to the C. D will be not there in vault prolapse. So can you see this is the vault prolapse? This is not uterine prolapse. Okay, this is vault prolapse. Now can you see +3? Okay, so that means maximum prolapse of A point. BA has come to 8. Okay, BA has come to 8. Total vaginal length is 10. Correct? So total vaginal length minus 2, 8. And it is equal. So equal to 8 means it becomes stage 4. Equal to or more than becomes stage 4. And can you understand?
Yes, ma'am.
Yeah. Now C point is again 8. So that means also TVL minus 2. So it is also stage 4. Because TVL is 8 here. Okay, sorry. TVL is 8, that means it is complete procedentia. Okay, if it is 10 also, it will become stage 4 only. If the TVL is 10 also, it will become stage 4 because 10 minus 2 is 8. So anything 8 or more becomes stage 4. Less than 8 will become stage 3. Clear? There is no role of as the GH and PB in the classification of prolapse, in staging of prolapse. Okay. Only thing here we can see there is widening of the genital hiatus and perineal body has become small. Okay. So clear now? What is stage 4 and what is here? They have given both stage 1 and stage 4 has been given. Clear or
Yeah.
not? Yeah.
Yes, ma'am.
Yes. Now you can see. Now what is this? Whether it is a uterine prolapse or vault prolapse.
It's a uterine prolapse.
Uterine.
Yeah, because both C and D are there, that means it is a uterine prolapse. Only C is there, that means it is a vault prolapse. Now can you see whether it is a, can you tell me whether it is a stage 3 or stage 4? Because it is seen outside. Now
Stage
only we
3.
have to see.
Stage 3.
Why stage 3? Why not stage 4?
9 minus 2, 7.
So it is equal to or more than, no? More than or equal to. So that means 7 is included in
Oh,
stage 4.
okay, stage 4.
Got
Stage
it, no?
4.
Yeah. Yes.
Yes, yes.
So it is more than or equal to, so it is included in stage 4 or stage 1 also for that matter. Sorry, not included in stage 1, stage 0. Yeah. Now what is this?
Anterior compartment defect.
The anterior wall prolapse.
Yeah. Vault or what?
Anterior vaginal wall.
Yeah, but it is related to vault or uterine.
It's vault because
It is
vault
vault.
because D is not there.
Vault. Yes. Okay. So AA is +3. It is 6. TVL is 6. Correct? BA point has come to 6. That means it is stage 4 anterior compartment. Got it?
Yes, yes,
But
yes.
now vault has come to -2. Vault is still inside. It is -2. So that means it is stage 1 vault. Am I right?
Can you just repeat how is it stage 4 anterior wall prolapse?
TVL is 6. BA has come
Okay.
to 6. So it is TVL. Almost at the length of TVL it has got
Same.
prolapse.
Okay,
So it is
okay.
stage 4. Okay. Anything
Yes,
more
yes.
than 4. 4 or more than 4 becomes stage 4 here because TVL is 6. Okay. Now here C point is at -2. That means vault is not stage 4. It is stage 4 anterior. But vault will become stage 1. Am I clear?
Yeah. It's inside only.
It is inside and it is not above -4. So
Yes,
it is
then
stage 1.
forward.
And what about posterior? What is BP?
Is
That
BP
is
is
BP is
recto
again
stage 1.
still
It's
-2. It is
it
stage
is
1.
-2.
So it
So
is
it is
again
stage
stage
1
1.
only.
Got it?
Yeah.
Yeah. Clear how you are going to stage it compartment wise? You have to stage it. Okay. Now, yes, there is no picture. Tell me
Plus 3.
whether it is uterine or wall prolapse first.
It is uterine prolapse.
It is uterine. D is there.
Yes, very good. Now, regarding anterior,
Anterior wall has come out to outside up to plus 3.
Stage-
So it is
Stage
maximum.
4.
So it is stage
Stage-
4.
no,
No, stage 3.
it is
Stage 3.
8
8
minus 2
minus
is
2.
6.
2.
It is less than
6.
6. It is less than 6.
Okay, okay. Yeah.
Okay.
It
So
is
it
So
is
stage
it will
stage
be
3.
stage 3.
Even
anterior compartment stage.
apical compartment also stage 3. Cervix has also come outside, but it is plus 3 centimeter. So that means it is stage 3. Correct?
Yeah.
Yes.
And what about
And
posterior
this
now?
is
Posterior.
0. That means it is stage 1.
No.
Stage
Stage
2.
2.
Stage
Stage
2.
2.
Stage 2.
Anything
It is
minus
at
1 to plus 1 is stage 2.
Stage 2.
So minus 1, 0, plus 1. All three are
okay,
stage 2.
okay. Yeah. Stage 2.
Okay. So it is final diagnosis is anterior stage 3, apical compartment stage 3, and posterior compartment stage 2. Got it? Yes. Now,
7 minus.
So it is 7 minus 2 will be 5. So it is the maximum.
So 4.
So
Yeah.
plus 5.
Anterior
Stage
compartment.
4.
So it will be
everything is
Stage
plus
4.
4.
it is stage
Everything is
4.
plus stage 4.
4.
Anterior, apical, and posterior all are stage 4.
Posterior. Yeah.
Agree?
Yes.
Yeah.
Yes.
Yes. Now we will do with questions. Yeah.
Ma'am, can I ask a doubt?
Yes.
If there is a discrepancy between C and D, like
Posterior.
both are given.
Yes. Got it.
Yeah, that is C is within 2 centimeters. Like suppose TVL is 9 and C is 8 and D is 6. Like
TVL is 9. How can become D will become 6? Because posterior fornix will be always deeper. When you are telling you are checking discrepancy, no? So you can tell that C is 3 or 4. That means you can tell it is cervical elongation.
I mean the opposite. Like D is 8 and cervix is lower down. So
Yeah.
you can say it is infravaginal elongation of cervix, or
Yeah, that's what I'm telling.
do you have?
So in that case, what will happen is only thing D and C distance there will be so much of discrepancy. In that case, you can tell it is the extra that is cervical elongation. Okay.
In that case, we don't have to stage the prolapse.
Cervix we don't have to stage. Okay. In that case.
Okay. Okay, ma'am.
Yeah. Okay. So. Yes. For your this thing, if you can't identify it, first black line is the abdominal pressure, second line is the vesical pressure, third line is the detrusor pressure. Yes, answer.
Vesicle has increased and detrusor has also
It is
increased.
detrusor overactivating. Detrusor
Yeah,
overactivating.
So it is detrusor overactivity,
Yes, it is detrusor overactivity, but leak is not there.
it is detrusor overactivity. There is no incontinence.
Yes, correct. So
Yeah,
it
yeah.
is E.
So it is
E. Correct? Agree? Yeah. Answer is E.
yes.
Yes.
Yes, ma'am.
Yes. Abdominal pressure, vesical. Black is abdominal, blue is vesical, red is detrusor pressure, and this is the video urodynamics.
Is it E cough provoked detrusor overactivity?
Why? Where is
Because
the
there is
No,
no
it is stress.
incontinence.
It is, there is increase in abdominal as well as
Systolic
vesical pressure.
Yeah.
So abdominal vesical pressure
Urodynamic
has
stress
increased,
incontinence.
Yeah.
and it is stress incontinence, urodynamic.
Yeah. Now here
A.
leak is not there. Here in
Urodynamics
graph
is
leak is
incontinence.
not there, but video urodynamics, this graph, the X-ray,
She
you
has
can
given
see
a
this
history
leak.
also.
Can you see this leak in the X-ray?
Yeah,
Yes.
the
Here
black
the leak is
line.
not given, but here you can see the leak. So it is urodynamics SUI. Clear? There is no detrusor overactivity. There is no increase in the detrusor
Yeah.
pressure. Okay? Yeah. Clear? Agree?
Yes.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yes. Yeah. Now this is very easy. We have done it so many times. Whether it is a
Urethral
pressure means feeling or voiding.
It is
Voiding, ma'am.
voiding only.
This is voiding. Yeah.
voiding.
What is this?
The peak has come and then
It's the
it is slowly reducing.
Uretral
See,
stricture.
peak is very less here. They have given this is 50. So here every line corresponds to 5 only. So it has
How
not
much?
reached 15.
Okay, okay.
Huh?
urethral stricture.
The urethral stricture.
Why urethral stricture? See here, no peaks are seen. It has been
External
plateaued. Slowly it has. There
Ma'am,
are no spikes.
It's a cystocele.
Yeah.
Cystocele.
External obstruction. It is cytocele. Okay. It is bladder outlet obstruction. But from outside. So it has plateaued slowly. Correct?
Yes.
So it is
Yeah.
cystocele.
Pressures. E.
Cystometry, ma'am. E.
Yes, this is E because it is a stress urinary incontinence and she wants to undergo TVT, correct? Transvaginal tape. So she wants to know exactly what is the diagnosis because she wants to know regarding the risk of failure. So it is the urethral pressure profilometry because we have to see whether it is a because of hypermobility. Because hypermobility will be corrected by this tape, okay? Intrinsic sphincter deficiency we can't correct with the tape. Got it? Next.
E. E.
E, ma'am.
E.
Right. E.
What?
There will be rise in vesical pressure, abdominal pressure without detrusor pressure rise.
But
Associated with leak.
But
associated
D.
with leak. So it
associated
will
with
be
leak.
D. It is
Ma'am,
not E.
D. D. D.
D. It is D.
Within.
D. It is not
D,
E.
ma'am.
Yes. Answer is D. Now first question.
B.
AP.
It is
AP.
Yes. Answer is B. AP and
AP.
BP. Both are the posterior wall points. Okay. So it will be the answer. Okay.
Second one is D.
D. D.
Yeah. Yeah. That we know.
Point D.
Yes.
That is D.
Yes. Yes. So over. Clear with PopQ and urodynamics?
Thank you,
Yes.
Dr. Murtala.
Yeah. Okay. Thank you guys. Chalo. Next time we will sometime
Thank you,
do
ma'am.
CTG. Yeah.
Thank you, ma'am.
Thank you, ma'am.
Yeah. Yeah.
Thanks a lot.
Thank you.
Yes. Bye. Bye.
Thank you, ma'am.
Thank you, ma'am.